Michael, you were somebody that was offered and then went on to have immunotherapy.
Correct.
Tell us your story. What were you started on after the chemotherapy?
After the chemotherapy, I had a successful run of 9 months where my scans were clean. After 9 months, my cancer had reappeared in 3 lymph nodes.
So that was picked up on scan, no symptoms at all?
Correct, correct. Picked up on scan, no symptoms at all. And that's when we had a conversation with my oncologist and on where I'm at now, what this means, and what my next course of treatment may be. More or less, I had an option of the regular run-of-the-mill treatment that is provided, or, which is very new now, at the time, was the immunotherapy clinical trial that Fox Chase was offering at the time. And it was explained to me very well, and I chose the path of the clinical trial, partly because of my love for science and, you know, wanting to be a guinea pig.
Sandy, when you heard about the option of a clinical trial,
Yeah.
what were your thoughts about that at that point?
Well, I wasn't as sure as he was, but you know, I was willing to take a look at it. They had offered something that had been approved and that was working for a lot of patients, something that he could have probably done locally, but when they discussed this clinical trial that they were offering at Fox Chase, that's what he decided to go with. So, you know, usually he doesn't make decisions for himself that fast, but this one is something he really wanted to do and he really had faith in and believed in.
Jeanne, we've spent some time on previous segments of Cure Connections focusing on the role of clinical trials and patients getting access to clinical trials. We know that for many cancer patients, they're very hesitant to go on a clinical trial, that they may interpret that as being end stage, that they failed all conventional treatments and that they already have advanced disease, or may fear that they're going to be exposed to a treatment that's not tried and tested. There may not be evidence to support that. Do you get asked questions about clinical trials, patients' hesitancy to go? That obviously Michael was very keen to get on as soon as possible. But
well, if they're already established at Fox Chase, then Betsy would be the one to bring that up and discuss it. I see them as new patients. A lot of times they're referred to us from other oncologists to discuss clinical trials. So we see if they're eligible for certain clinical trials on our initial interview. But we do get patients that come for that reason, because they research it, or even the urologist is aware of a clinical trial. And
I think there's a lot more awareness. We really try to communicate to patients that we only open trials that we feel are good trials, that we would put a family member on that we feel are fair. So there's a lot of concern around placebo. Patients don't like that. We rarely have placebo trials, certainly not in the metastatic setting where we know we have other options. Blinding, where you're not sure what you're getting, is another thing. It's more rare now. A lot of them are open label, and we prefer that. I think we like to be open with the patients. We as the doctors like to know what we're giving. In some situations it's important to have blinding or placebo to know the answer, but we explain really carefully when that's the case to patients. So having them understand what's known, what's not known, and that the choice is always yours to participate or not is part of our mission.
Sure. We know the world's become a very small place now with access to internet and patients able to go on blogs and learn about these new treatments, and obviously some of these clinical trials are available nationally. If a patient is Googling around and sees that you offer these kind of treatments at Fox Chase, particularly these newer clinical trials, but they live 250 miles away, are you or Jeanne able to help connect those patients with centres that may be able to offer the same treatment nearer to home?
So absolutely. For trials that we're on, we know the other centres that have them. The other thing is they're encouraged to ask at their local center what clinical trials may be available. I think the Bladder Cancer Advocacy Network is really working to make access to understanding what trials are available to patients using tools and online resources, but I think we as medical oncologists have to play an active role in helping our patients get to the right trial, whether it's at our institution or at one of our colleagues.
Right. So. Now, we know that patients who are having this immunotherapy, there's certain receptors on tumours that determine whether cancers will respond to these chemotherapy, to immunotherapy. For patients who are coming up to having a biopsy or coming up to having surgery where we're actually getting a tissue diagnosis, is there any role for patients in getting the surgery done at a place where that pathology tissue may be used to guide treatment? So for example, if they have their surgery done at Fox Chase, can the pathologist use that tissue to look at various markers or receptors in tumours that then would make them eligible to your treatment, where we really send a message to patients, look, you need to be in the right centre early on, even at the point of having your initial surgery, or is that not relevant to patients'
So
care?
obviously being at the right place for your initial surgery is critical, but not so much for the diagnosis and pathologic regions that you mentioned, more based on things we talked about in prior segments in terms of being comfortable with the decision making and the skill set of your surgeon. Once the tissue is extracted, either through surgery to remove the bladder or the transurethral procedure we talked about earlier, that tissue is preserved, and every hospital will preserve that tissue for us. All of the testing, and right now it's all experimental, that we do on that tissue can be done from a preserved specimen that we can request from the outside. So we're very good at doing that. Sometimes we have to do new biopsies to get fresh tissue to do these analyses. Right now, the molecular analysis and the staining that we're trying to develop tests that will tell us exactly what treatment to assign to a patient. We're not there yet, but we're getting there with research.
Right. If you'd have met Michael 10 years ago, or even 5 years ago, the treatments that he's having right now were really not even available to us 5 years ago. In 5 years' time, where do you predict we will be in managing bladder cancer? Will we still be looking at, do you think, more advanced immunotherapy drugs? Do you think there's a role for gene therapy, or will we not even have bladder cancer in the future? Will we have actually been able to manipulate genes to prevent the disease?
Yeah, all those things. I mean, there is active research going on in all the areas you just mentioned. Prevention, better surgical techniques, understanding who needs surgery, better staging so we understand where the disease is, and better treatments for metastatic disease. And I think because technology has evolved so briskly, we have better and better tools to inquire and to test. But really, we couldn't do it without you. We couldn't do it without the patients who have the courage to volunteer for these trials and test these treatments, right? We make the trials the best we can make them with the goal of helping each patient, but we don't know the answer until we can prove the answer. And so we're so grateful to Michael and all the patients at Fox Chase and elsewhere who have the courage really to volunteer for these trials in hopes that it'll help them, but they all end up helping others.